Welcome to the Hospital Medicine Unplugged podcast. Today we are looking at a diagnosis that many of us might consider, a relic of the industrial past, yet it remains a significant and actually a peaking clinical burden on our wards and in our clinics today. We are talking about asbestosis.
It's a fascinating and frankly a somewhat tragic paradox in modern medicine. We look at the regulatory landscape, the EPA bans, the abatement protocols from the late 20th century, and we sort of assume this is a solved problem.
Right. We think that's been dealt with.
Exactly. But the clinical reality, it operates on a completely different timeline. Because of the extreme latency of this disease, which I know we'll get into in depth, we are currently navigating the peak incidence for patients who were exposed during the industrial heights of the 1970s and 80s.
That lag time is just, it's extraordinary. And I think for many of us, hospitalists and clinicians, there's a tendency to sort of lump all fibrotic lung diseases together. We see honeycombing on a CT scan, we hear those fine velar crackles on exam, and we document interstitial lung disease or pulmonary fibrosis in the chart. But today, we're going to be very, very specific.
We have to.
We're going to distinguish asbestosis from other ILDs like idiopathic pulmonary fibrosis. We'll unpack the pathophysiology, which is distinct, the diagnostic criteria, and the massive malignancy risk that goes far beyond just mesothelioma, and then the shifting paradigm in management.
And that management piece is really the most critical update for the practicing physician today. For decades, the approach to asbestosis was essentially nihilistic.
Right. There was nothing to do.
Nothing. We diagnosed it, we documented it for legal or compensation purposes, and then we just watched it progress. Now, with the advent of antifibrotics and this regulatory recognition of the progressive phenotype, we actually have meaningful interventions.
So there's something we can offer.
Yes, but to really understand why a tyrosine kinase inhibitor might work in a lung filled with mineral fibers, we have to start at the beginning. At the molecular level, we need to understand the injury itself.
Let's do that. Let's start with the pathogenesis.
Yeah.
We're talking about an inhalational injury, but this isn't like smoke or some kind of soluble toxin. When a patient inhales these fibers, what is the specific sequence of events in the lung parenchyma? We know the lung has these robust defense mechanisms, the mucociliary escalator, the cough reflex, but they fail here. Why?
They fail, and the manner of their failure is what drives the disease. So when asbestos fibers are inhaled, particularly the smaller dimensions that we'll define later, they bypass all that upper airway clearance and they deposit deep in the distal airways and the alveoli.
Right down at the gas exchange level.
Exactly. And the primary responder there is the alveolar macrophage. Now, in a typical scenario, let's say with organic dust or a bacterium, a macrophage will come along, it'll engulf the particle, the phagosome fuses with a lysosome, enzymes digest the material, and the cell clears it. Problem solved.
But asbestos is inorganic. It's a mineral. It's basically a rock.
Correct. And it's a mineral with very specific physical properties that defy this process. The fibers, particularly the amphibole types, are often much longer than the diameter of the macrophage itself.
So the cell physically can't eat it?
It can't. And this leads to this phenomenon that's described in the pathology literature as frustrated phagocytosis.
That term is incredibly evocative. But let's break down the cellular mechanics. What is actually happening when that macrophage just can't close the loop?
Well, the macrophage makes the attempt. It tries to engulf the fiber, but it can't completely seal the phagosome around it. Think of it like trying to swallow something that's sticking out of your mouth. This incomplete closure prevents the containment of the intracellular digestion process.
So all the toxic stuff leaks out.
Precisely. You get leakage of lysosomal enzymes like cathepsin B and a huge flood of reactive oxygen species, or ROS, into the cytoplasm and then into the extracellular space. This lysosomal destabilization is a very potent trigger for something called the NLRP3 inflammasome.
Okay, so this is activating the innate immune cascade. We're flipping a switch here.
We're flipping a major switch. It acts as a continuous signal 1 and signal 2 for inflammation. So the NLRP3 inflammasome assembles. It leads to the activation of caspase-1, which then cleaves pro-IL-1 beta and pro-IL-18 into their active inflammatory forms.
So the frustrated macrophage, as you called it, basically becomes a factory for inflammatory cytokines.
A nonstop factory. It's just churning out things we know well. Tumor necrosis factor alpha, or TNF-α, interleukin-1, and ultimately the big one for fibrosis, transforming growth factor beta, or TGF-β.
And TGF-β, that's the cytokine that really bridges that gap between the initial inflammation and the eventual scarring. the fibrosis.
It is the master regulator of fibrosis in almost every organ system. TGF-β drives the differentiation of local fibroblasts into myofibroblasts, and these myofibroblasts are the effector cells. They're the ones that lay down the excessive extracellular matrix, tons of collagen and fibronectin, that ultimately remodels and destroys the normal alveolar architecture.
It's like paving over a garden.
That's a perfect analogy. But there's another layer to this injury beyond just the cytokine signaling. We also have to consider the chemistry of the fiber itself.
Right. The source material we reviewed really highlights the role of iron in this process. So this isn't just a physical irritant like a splinter. We're dealing with a chemically reactive structure.
Absolutely. Many asbestos fibers, especially the amphiboles like chrysotolite and amosite, have a significant amount of iron content right on their surface. And this iron participates in what's known as the Fenton reaction,
which generates hydroxyl radicals, the most reactive of the ROS.
Exactly. High concentrations of hydroxyl radicals. So you've got this double whammy. You have the oxidative burst from the macrophage trying to kill the fiber, and you have the fiber itself acting as a catalyst for ROS generation. This creates a zone of incredibly intense oxidative stress right next to the alveolar epithelial cells, the AECs.
And the AECs are really the innocent bystanders here that just get wiped out in the crossfire.
They are the primary victims of this whole process. The oxidative stress causes direct DNA damage and mitochondrial dysfunction in those epithelial cells. This triggers apoptosis, or programmed cell death, through p53-regulated pathways and mitochondrial leakage.
So the cell's power plants are failing.
They're failing, and they're sending out death signals. The sources also emphasize something called endoplasmic reticulum stress, or ER stress, as another key driver. The cell's protein folding machinery becomes completely overwhelmed by the damage, leading to the unfolded protein response and eventually cell death.
And this loss of the epithelium is just so crucial because in all the lung fibrosis models we see, it's the failure of reepithelialization and the failure of that lining to heal itself that allows the fibroblast to run wild underneath.
That is the absolute core of the pathogenesis. You have this chronic, unrelenting epithelial injury because of the persistent fiber, combined with a total failure of the normal repair mechanisms. This leads to unchecked fiber proliferation. The fiber never goes away, so the injury signal, it never stops.
That persistence is a perfect segue. It brings us to the toxicology and the different types of asbestos. In medical school, we learn the broad categories, but clinically and frankly legally, the distinction between the fiber types is massive. We categorize them into amphiboles and serpentine.
And that distinction is vital for understanding a patient's risk profile. Serpentine fibers, which is primarily chrysotile, accounted for the vast majority, probably 90 to 95% of global commercial use. This is the white asbestos that was used in brake linings, roofing, insulation, all sorts of things.
But the amphiboles, those are the ones that keep pulmonologists and occupational medicine doctors awake at night.
They really are. The amphiboles, specifically chrysotolite, which is the blue asbestos, and amosite, the brown asbestos, are significantly more fibrogenic and also more carcinogenic. The difference really lies in two key properties: their biopersistence and their aerodynamics.
Okay, let's talk about the aerodynamics first. How does the physical shape of the fiber dictate the injury it causes?
It's fascinating, really. Chrysotile fibers are curly, they're pliable, almost like a piece of yarn under a microscope. Because of this shape, they're much more likely to impact in the upper airways. The mucociliary escalator can catch them, and they get cleared out.
So they get trapped before they can do the deep damage.
Right. Amphiboles, by contrast, are straight, stiff, rod-like structures. They act like microscopic needles. Because they're so straight, they align with the laminar airflow in the airways and can penetrate deep into the lung periphery, right down to the subpleural alveoli where gas exchange happens.
And once they lodge down there, they stay.
And that is the biopersistence factor. The lung has a very, very limited capacity to clear amphibole fibers. They can remain in the lung tissue for the patient's entire lifespan.
What about chrysotile? Does it get cleared?
Chrysotile, because it's more soluble in tissue fluid and it's prone to fragmentation, can be cleared over time. It's certainly not harmless, but its clearance is much more efficient. But the half-life of an amphibole fiber in the lung is measured in decades. It's essentially a permanent resident.
There's this concept mentioned in the occupational health literature, the Stanton hypothesis, about a specific geometry of risk.
Yes. Stanton and Lehrer did the seminal work on this back in the 70s. They implanted different fibers into the pleura of rats and identified that fibers with a high aspect ratio, meaning long and thin, are by far the most dangerous.
So there's a specific size and shape that's the sweet spot for toxicity.
There is. Specifically, fibers that are longer than about 10 to 20 micrometers and thinner than 0.25 micrometers.
0.25 micrometers. That is incredibly narrow.
It's almost unimaginably thin, and that specific geometry allows them to do two things. First, it allows them to bypass the macrophage's phagocytic limit. If a fiber is longer than the macrophage itself, which is about 10 to 15 micrometers, the cell can't engulf it. That's our frustrated phagocytosis.
And the thinness lets it penetrate.
Right. The thinness allows it to weave through the tissue and penetrate deep. This specific dimension creates the maximal biological dose, the perfect storm for persistent cellular injury.
And all of this really helps explain the latency period. I mean, we have a mechanism for this chronic, low-grade simmering injury that just accumulates over decades and decades. So let's shift to the clinical presentation in that timeline. Asbestosis is not an acute disease by any stretch.
No, it is the absolute definition of a slow burn. The latency period typically ranges from 20 to 40 years, sometimes even longer, from the first exposure to the first clinical manifestation.
So a patient presenting to our hospital today with new dyspnea could have worked in a shipyard in 1985 and been completely asymptomatic for that entire interim period.
Absolutely. And that's a classic history. The sources we looked at note that the peak incidence of asbestosis actually occurs 40 to 45 years after the onset of exposure. What's interesting is that this is even later than the peak for asbestos-related lung cancer.
That is interesting. Why the difference?
Well, lung cancer peaks slightly earlier, maybe around 30 to 35 years. The thinking is that the interaction with other carcinogens, especially smoking, might accelerate that oncogenic process. But for fibrosis, it just takes that much time for the cumulative scarring to remodel the lung architecture to a point where it becomes symptomatic or, visible on imaging.
I want to focus on this concept of the progressive phenotype, because this is really where the modern treatment paradigm comes in. I think there's a perception that once exposure stops, the disease sort of burns out. But that's not true, is it? Not every patient with asbestosis progresses at the same rate.
Not at all, and this is the most challenging aspect of management. Historically, we did think of the pneumoconiosis as somewhat static once exposure ceased, but cohort data now shows that about 20%, maybe up to 30% of patients exhibit a progressive course even decades after they've left the exposure environment.
So the fire keeps burning on its own.
It does. We define progression clinically as an annual decline in forced vital capacity, or FVC, of greater than 100 milliliters.
Okay, let's put that number in context for you listening. The normal age-related decline in FVC for a healthy adult is roughly 20 to 30 milliliters per year. So we're talking about a rate of lung function loss that is 3 to 5 times the physiological norm. It's a steep cliff.
It's a very steep cliff. And in high-risk groups, we're talking about those with what's described as a fibrotic or mixed pattern on high-resolution CT. Some studies show the mean decline can be around 77 to 100 ml per year. That is a rapid trajectory toward respiratory failure and oxygen dependence.
So the clinician's primary job, after making the diagnosis, is really to identify who is on that steep slope versus who is relatively stable.
That is the crucial distinction that dictates our modern management.
Speaking of the diagnosis itself, this can be a gray zone. We don't have a specific blood test for it. The American College of Chest Physicians, the ACCP, has laid out some consensus criteria.
Yes, the diagnosis really relies on a convergence of evidence. It's not one single thing. It requires 4 pillars to be in place. First, and this sounds simple but it's not, is a reliable history of significant exposure.
And quantifying significant can be really difficult.
Very. We're not just talking about the asbestos miner or the insulator. We have to think about the electrician who worked next to the lagging crew, or the boilermaker, or even the spouse who was washing the workers' clothes for 20 years.
The classic take-home or bystander exposure cases.
Exactly. Those cases require some really deep digging in the social and occupational history. So that's pillar 1. Pillar 2, you need that appropriate latency interval we just discussed, 20 plus years. Third, you need radiographic evidence of interstitial fibrosis. And fourth, you need physiologic evidence of impairment, which is typically a restrictive defect on pulmonary function tests with a reduced diffusing capacity of the lung for carbon monoxide, the DLCO.
Let's drill down on the imaging, because this is what we as hospitalists are looking at most of the time. Chest x-rays were the old standard for screening with the ILO classification system, but in modern hospital medicine, we're really relying on the high-resolution CT or HRCT. What are the specific patterns we should be looking for that can help distinguish asbestosis from, say, IPF or nonspecific interstitial pneumonia?
This is a key question. The single most specific finding for asbestosis on an HRCT scan is the presence of subpleural curvilinear lines.
Can you describe what those are, the anatomical basis of those lines?
Sure. These are very fine linear opacities that run parallel to the pleural surface. They're usually within a few millimeters to a centimeter of the pleura itself. They represent fibrosis and maybe some edema of the perilobular lymphatics and the interlobular septa right at the edge of the lung. When you see those lines, particularly in the lower lobes and the posterior zones of the lung, it is highly, highly suggestive of an asbestos etiology.
We also see something called parenchymal bands. What are those?
Yes, parenchymal bands are a bit different. They're coarser, thicker, linear opacities, often 2 to 5 centimeters long, that extend from the visceral pleura deep into the lung substance. These represent significant fibrosis along the bronchovascular sheaths or collapsed and scarred interlobular septa. It really creates a very different visual texture than the classic reticular honeycombing of UIP or IPF.
But in end-stage asbestosis, you can get honeycombing that looks just like UIP.
You can, and that mimicry is the danger zone for misdiagnosis. If you see advanced fibrosis with honeycombing, you might immediately think IPF.
So how do we differentiate advanced asbestosis from idiopathic pulmonary fibrosis in that scenario? What's the tell?
The pleural disease. The pleural disease is the absolute key differentiator. Asbestosis is almost invariably accompanied by pleural changes. The source data we reviewed suggests that up to 98.5% of patients with established asbestosis will have either pleural plaques or diffuse pleural thickening.
So if I have a patient in front of me with basilar fibrosis and honeycombing, but their pleura is completely pristine on the CT scan, I should be thinking IPF, not asbestosis.
Or another ILD, certainly, but asbestosis would be extremely unlikely. Conversely, if you see calcified pleural plaques, especially on the diaphragm, that is the hallmark. Diaphragmatic plaques are incredibly specific for asbestos exposure. They are essentially a radiologic fingerprint that the fibers have left behind.
A permanent marker of exposure.
Okay.
Let's move to the topic that arguably carries the highest mortality burden with this disease, malignancy. There's this persistent misconception in the lay public, and I think even among some providers, that asbestos equals mesothelioma.
It's a branding issue in a way. Mesothelioma is what you might call the signature tumor because it is so incredibly specific to asbestos exposure. But statistically, it's not the biggest killer. Asbestos causes anywhere from 2 to 6 times more cases of lung cancer, your standard bronchogenic carcinoma, than it does mesothelioma.
So lung cancer is the dominant oncological killer here.
By a wide margin. And the risk for lung cancer is not simply additive with smoking, it is multiplicative. The synergy is, frankly, terrifying.
Walk us through those numbers.
The data on this is some of the most robust in all of occupational epidemiology, coming from the Hammond cohorts and subsequent studies. If you take a non-smoker who was exposed to asbestos, their risk of getting lung cancer is elevated. It's about 3.6 times the baseline risk of an unexposed non-smoker.
Okay. Significant, but maybe not astronomical.
All right. Now look at a smoker with no asbestos exposure. The risk is about 10 to 12 times baseline, which we all know is very high. But when you combine the two risk factors, a smoker with asbestos exposure, the risk doesn't just add up to 15 or so. It jumps to a rate ratio of roughly 50 to 55 in some of the classic studies. And in the specific context of patients who already have established asbestosis, the lung cancer mortality rate ratio is 36.8.
Let's just pause on that number for a second. A nearly 37-fold increase in the risk of dying from lung cancer for smokers who also have asbestosis.
It's a supra-additive or synergistic effect. The proposed mechanisms are that the asbestos fibers impair the mucociliary clearance of tobacco carcinogens, allowing them to sit in the airway longer. And the chronic inflammation and cell turnover from the fibrosis itself makes the epithelium more susceptible to DNA adducts from the smoke. It just creates a perfect oncogenic environment, a perfect storm.
This brings up an important practical point, the Helsinki criteria for attribution. For any physician who might be involved in a medical legal consult or an occupational health assessment, how do we determine if a specific patient's lung cancer is actually due to their asbestos exposure?
The Helsinki criteria are the accepted international standard for this. They generally state that you can attribute a lung cancer to asbestos if one of two conditions is met. Either the patient has a confirmed diagnosis of asbestosis.
So the presence of the fibrosis itself is enough.
Exactly. Or if there's no asbestosis, you need a sufficiently high fiber burden in the lung tissue, which has historically been quantified as 25 fiber years of exposure. But for most clinicians, the simpler rule is that the fibrosis itself serves as a biological dosimeter. If you can see that the patient has enough fiber burden to physically scar the lung, then you can be confident they had enough to cause the cancer as well.
Mesothelioma, on the other hand, seems to be less dose-dependent and much more fiber-type dependent.
That's very true. The risk of mesothelioma is heavily skewed toward the amphibole fibers. The risk with pure chrysotile exposure is debated, but it appears to be orders of magnitude lower.
Can you quantify that?
Sure. For chrysotolite, the blue asbestos, the risk is estimated at roughly 0.51% per fiber year. For chrysotile, it might be as low as 0.001%. This is why the mining cohorts from places like Whitnum, Australia, where they mined blue asbestos, have these absolutely catastrophic mesothelioma rates compared to, say, the Quebec chrysotile miners, whose primary risk was lung cancer.
Okay, let's shift gears now to management. This is really where the conversation has changed the most in just the last 5 to 10 years. We're finally moving away from supportive care only to active disease modification.
It's a huge shift. We are seeing the migration of antifibrotic therapy from the world of IPF, where it was first established, into the broader world of progressive fibrosing ILDs, a category that now officially includes asbestosis.
We have two main players on the field right now, nintedanib and pirfenidone. Let's start with nintedanib, and specifically the ION-BUILD trial.
The ION-BUILD trial was the landmark study that really changed the game. It was brilliant in its design because it didn't just recruit asbestosis patients. It recruited patients with any chronic fibrosing ILD that was showing a progressive phenotype.
So it was agnostic to the original diagnosis.
Exactly. It included patients with hypersensitivity pneumonitis, autoimmune-related ILDs, unclassifiable ILDs, and yes, a subgroup with asbestosis and other pneumoconioses.
And the inclusion criteria for what they call progression are really important here. Yeah. What did the patient have to demonstrate to get into that trial?
They defined progression in a few ways over a 24-month period. It was either a relative decline in FVC of at least 10% predicted, or a more moderate decline of 5 to 10%, but with worsening respiratory symptoms or worsening fibrosis on imaging. Or you could get in with just worsening symptoms and worsening imaging alone.
So it captured the clinical reality of a deteriorating patient. What did the data show for the overall cohort?
The data was striking. Nintedanib, which is an intracellular tyrosine kinase inhibitor that targets receptors for VEGF, FGF, and PDGF, all key growth factors in fibrosis, it reduced the annual rate of FVC decline by 57% across the entire population compared to placebo.
So it's not a cure, but it preserves lung function. It cuts the rate of decline in half.
It effectively slows the disease progression by half. Now, when we look specifically at the subgroup analysis for the pneumoconioses, the numbers of patients are smaller, so the confidence intervals are wider, but the trend is entirely consistent. And this is what led to the FDA approval for nintedanib for the broad indication of chronic fibrosing ILDs with a progressive phenotype. That is the green light for us to use it in our asbestosis patients who are deteriorating.
What's the story with the other drug, pirfenidone?
The data there is a bit less robust for asbestosis specifically, but it still points in the same direction. There were prospective studies, like the RELIEF trial, that looked at pirfenidone in non-IPF fibrosis. In the asbestosis-specific context, smaller studies showed that it has an acceptable safety and tolerability profile. In terms of efficacy, some data using home spirometry suggested it might attenuate the FVC decline, but many of these studies were underpowered to show definitive statistical significance in the asbestosis subgroup alone.
But biologically, the rationale holds up. The mechanism should work.
It absolutely does. If the final common pathway of fibrosis is TGF-β-driven collagen deposition, then blocking that pathway with a drug like pirfenidone should work regardless of whether the initial trigger was asbestos or silica or something we can't even identify. We are no longer treating the label. We are treating the behavior of the lung. We're treating the progressive fibrosis itself.
So let's map out the clinical algorithm for you, the listener. It's now: 1, diagnose asbestosis using the criteria we discussed. 2, Monitor their PFTs serially, maybe every 6 months. And 3, if you see that drop, that loss of 100 ml or more per year, or that 5 to 10% drop with worsening symptoms, you have a trigger to initiate antifibrotic therapy.
Precisely. It turns what was a wait-and-watch disease into an actively managed chronic condition. Of course, this comes with its own challenges, the need to manage side effects, GI upset and diarrhea with nintedanib, photosensitivity and rash with pirfenidone, but offers a real lifeline that we simply did not have before.
And throughout all of this, we cannot overstate the importance of the non-pharmacologic management, especially smoking cessation.
It is the single most effective intervention we have for improving mortality in this population. Remember that mortality rate ratio of 36.8 for smokers with asbestosis? Smoking cessation can cut that massive risk in half within 10 years of quitting. After 30 years, their risk converges with that of never smokers. We have to be relentless. Pharmacotherapy, counseling, whatever it takes.
Let's talk about screening. For our hospitalist colleagues who might admit a 65-year-old man for pneumonia, and in his social history you see a retired sheet metal worker for 30 years. What is the current standard of care for secondary prevention in that patient?
A great question. For lung cancer, we follow the general guidelines from the NCCN and the USPSTF. Low-dose CT, or LDCT screening, is supported for high-risk individuals.
And the criteria for that are typically based on age and smoking history.
Right, usually age 50 to 80 and at least a 20-pack year smoking history. However, what's important here is that the newer risk prediction models, like the PLCOME 2012 model, specifically incorporate asbestos exposure as an independent risk variable.
So even if their pack years are borderline, say 15 or 18, the significant asbestos exposure could push them into the high-risk category that warrants screening.
That's exactly right. For a patient with a documented history of significant asbestos exposure, our threshold to recommend LDCT screening should be lower. We know from the National Lung Screening Trial that it improves survival by detecting more early-stage, resectable disease.
And what about screening for mesothelioma? That's what the patients are often most afraid of. Is there any role for that?
This is a very common question from patients and families, but currently the answer from all major societies is no. There is no evidence that screening for mesothelioma, whether it's with serum biomarkers like soluble mesothelin-related peptides or with serial imaging, improves mortality.
Why is that?
The disease is just so aggressive, and our treatment options, even now, are so limited that catching it 6 months earlier does not statistically alter the ultimate outcome. It just results in lead time bias. The patient knows they have the disease for longer, but it doesn't result in a survival benefit, so we don't recommend it.
So we focus our resources on the one thing that is actionable from a screening perspective.
Yeah.
Lung cancer.
Yes, that's where we can make a difference.
Okay, so to bring this all together for our listeners, we've gone on quite a journey. We started at the microscopic level with that frustrated phagocytosis in the alveolus. We've moved to the macroscopic fibrosis and the clinical management of the patient in front of us.
And we know that it's the amphibole fibers, because of their specific geometry and their biopersistence, that really drive this process forward through inflammasome activation and unrelenting oxidative stress.
We recognize that even though the exposure was decades ago, the peak clinical burden is hitting our hospitals right now. We diagnose it by piecing together the evidence, the reliable history, the long latency, and those specific HRCT findings, the subpleural curvilinear lines and parenchymal bands, while always checking the pleura for those telltale plaques.
We understand the massive super additive synergy with smoking when it comes to lung cancer risk, making smoking cessation our #1 priority. And most importantly, we've identified a new therapeutic avenue. We actively look for that progressive phenotype. We don't just watch the FVC drop anymore. We intervene with antifibrotics like nintedanib to slow that decline.
It's a fundamental shift from treating asbestosis as a static medico-legal diagnosis to treating it as a dynamic, treatable clinical entity.
It really is.
So I want to leave our listeners with a final thought, one that sort of bridges these concepts of diagnosis and treatment. We are now treating progressive asbestosis with the very same drugs that we use for idiopathic pulmonary fibrosis. The biological downstream effects, that TGF-β-driven fibroblast proliferation and collagen deposition, are effectively the same. So my question is this: if the treatment is the same and the molecular mechanism of progression is the same, does the historical distinction between occupational fibrosis and idiopathic fibrosis start to matter less for the biologist and the clinician and more just for the lawyer?
That is the provocative question of our time in the world of interstitial lung disease. As we move toward treating mechanisms rather than labels, The boundaries between these historically distinct diseases are definitely blurring. The cause matters immensely for prevention and for compensation, of course. But once that fibrosis cascade is up and running, the lung behaves in a remarkably unified and unfortunately destructive way.
Something to consider the next time you're reviewing a chest CT in the reading room.
Thank you for joining us on this deep dive for Hospital Medicine Unplugged.
A pleasure to discuss it. Thank you.